Hello students, I am Dr. Arlene Williams, lecturer in pharmacology at the Paraclinical Sciences Department, Faculty of Medical Sciences, University of the West Indies, Intercustin. Today we're going to look at diuretic drugs. And the framework of today's lecture would be to look at all the different classes of diuretics, the point at which they work and their mechanism of action and side effects. We will also apply the use of the drugs throughout the lecture to their clinical applications in disease states such as in heart failure, hepatic cirrhosis, hypertension, nephrolithiasis, diabetes insipidus, and renal and cardiac protection, etc. So renal transport involves the kidneys, and within the kidneys there are millions of nephrons, and you would have covered the physiology of the nephron extensively. So in order to discuss diuretic drugs, we're going to look at their mechanism of action along the nephrons. In blood pressure, how does the kidney become involved? So the renal involvement is controlled by blood volume. So the kidney is primarily responsible for long-term blood pressure control. A reduction in renal perfusion pressure causes intrarenal redistribution of blood flow and increased distribution of salt and water. In addition, decreased pressure in renal arterioles, as well as sympathetic neural activity via the beta adrenoreceptors, if you recall your year 1 autonomic pharmacology, this stimulates the production of renin. And as a result, it increases the production of angiotensin II. Angiotensin II has two major effects: direct constriction of resistance vessels and stimulation of aldosterone synthesis in adrenal cortex. This increases renal sodium absorption and intravascular blood volume. The thiazides are usually the class of diuretics that are used to treat hypertension. And these diuretics are appropriate for most patients with mild to moderate hypertension with normal renal and cardiac function. While all thiazides can lower blood pressure, the use of chlorothiazide, as you see here, is preferred over the others because mainly of their longer duration of action and longer half-life. It is important to note too that their longer half-life is as a result of its binding to red blood cells. So thiazides work at the distal convoluted tubule. So what happens at the distal convoluted tubule is that very little sodium and chloride ions are reabsorbed, and the small percentage that is reabsorbed does so by the sodium chloride cotransporter, or the NCC. Like the thick ascending limb of Henle's loop that we'll see in a while, the distal convoluted tubule is relatively impermeable to water, producing a more dilute urine. Potassium is not recycled across the apical membrane compared to the thick ascending limb of loop of Henle, and there is no lumen positive potential created at this distal convoluted tubule segment. Therefore, calcium and magnesium remain in the tubular lumen, and instead calcium is actively reabsorbed, as you see in the diagram, by the distal convoluted tubule cells through the apical calcium channel and the basolateral sodium-calcium exchanger, and is regulated, and this process is regulated by parathyroid hormone, as you see in your diagram. The mechanism of action of thiazides is to inhibit the sodium chloride cotransporter, and this causes an increase in excretion of sodium and chloride ions. It is also important to note that thiazides are weak inhibitors of carbonic anhydrase, which increases bicarbonate excretion. It also causes an increase in magnesium and potassium excretion because of the blocking of the NCC cotransporter. So by increasing calcium reabsorption from the luminal membrane into the interstitial area in blood interstitium in exchange for sodium, thiazides are able to reduce calcium levels in the urine and increase blood calcium. So it increases or enhances the reuptake of calcium. And this effect gives it the ability to treat other causes such as nephrolithiasis and osteoporosis because of the ability to reabsorb calcium from the urine. So thiazides are orally administered, and the free drug enters the tubules by filtration. It also enters by organic acid secretion. You would recall that I mentioned chlorthalidone being more effective to treat mild to moderate hypertension in normal renal and cardiac function patients compared to hydrochlorothiazide or chlorothiazide. And this reason was because of their longer duration of action. And all the other drugs in this class have longer duration of action compared to chlorothiazide. And their longer half-lives. And this is because these agents, especially chlorthalidone, has the ability to bind to red blood cells, and it binds to the carbonic anhydrase component of the red blood cell. So despite differences in the pharmacokinetics of these agents, they are all sulfur-containing. As a result, this makes these agents capable of causing sulfonamide allergies. It is important to note that there are other more powerful diuretics, such as the loop diuretics, which we will explore in a little while, that are used to treat hypertension, especially those with renal insufficiency. Some of the major uses of thiazides, therefore, would be in the treatment of hypercalciuria, hypertension, mild chronic heart failure, nephrogenic, diabetes insipidus, and in the treatment of lithium-induced toxicity. The article below compares the pharmacokinetics or the uses of, chlorthalidone compared to hydrochlorothiazide in the treatment of patients with kidney stones. And this was done many years ago. So today, there's a lot of evidence to support it still. On the other hand, some of the side effects of thiazides include low sodium hydronatremia, hypokalemic metabolic alkalosis, sulfonamide allergies as mentioned before, hyperlipidemia, impaired uric acid metabolism or hyperuricemia, and impaired carbohydrate tolerance. Especially, it has to be monitored in patients with diabetes mellitus if given. Heart failure and the kidneys. When cardiac output is reduced in heart failure, changes in blood pressure and blood flow to the kidneys are sensed as hypovolemia, and this leads to renal retention of salt and water. Initially, this causes an increase in intravascular volume and venous return to restore cardiac output. But if for some reason cardiac output continues to be reduced due to some underlying disease, the expansion of plasma volume in the kidney continues, and this causes the kidney to retain salt and water, which then leaks from the vasculature and becomes interstitial or pulmonary edema, as we see in the cardiac pulmonary edema diagram of the showing a bronchiole. At this point, we use diuretics to reduce pulmonary edema. On the right-hand side, you'll see the X-ray showing a butterfly pattern consistent with cardiogenic pulmonary edema. A reduction in pulmonary vascular congestion with diuretics may actually improve oxygenation and therefore improve myocardial function. A reduction of preload can reduce the size of the heart, allowing the heart to work at a more efficient fiber length. Edema associated with heart failure is generally managed with loop diuretics, And in some cases, the retention of salt and water may become so severe that combination diuretic use, such as the use of thiazides with loop diuretics, may be considered or used in these patients. So diuretic overuse. In treating heart failure with diuretics, cardiac output is being maintained partly by high filling pressures. Therefore, excessive use of diuretics might continue to reduce venous return and further impair cardiac output. This is especially important in right ventricular heart failure, where systemic edema and vascular congestion are of greater importance. So diuretic-induced volume contraction predictability reduces venous return, and this can severely compromise cardiac output. If left ventricular filling pressure is reduced below 15 millimeters of mercury, a reduction in cardiac output from either the left or the right ventricular ventricles of the heart might eventually lead to renal dysfunction, resulting from reduced perfusion pressure. So diuretic-induced metabolic alkalosis caused by hypokalemia is another adverse effect that might cause further compromise of cardiac function. And this can be treated with the replacement therapy such as potassium and restoration of intravascular volume using saline. However, in severe heart failure, the use of saline in these patients might not be optimal. So in these cases, adjunctive therapy with another agent, acetazolamide, would help to correct the alkalosis. So hypokalemia can exacerbate underlying cardiac arrhythmias and contribute to digitalis toxicity on patients who are on digitalis. So by reducing the patient's sodium intake while taking diuretics, sodium intake in their diet, that is, when taking diuretics, this would reduce sodium delivery to the area of the collecting tubule where potassium is secreted, and patients who do not adhere to low sodium diet might need to take potassium chloride supplements or use potassium sparing diuretics, another class of diuretics that we'll explore in a little while. So there have been studies that support the less likelihood of electrolyte imbalance in patients who are on combination with diuretics and vaptans instead of increasing the dose of diuretics. So let's discuss some of the diuretics that I just mentioned, such as the loop diuretics, in the treatment of heart failure. Let's look at their mechanism of actions, etc. The loop diuretics. At the thick descending limb where the proximal tubule ends, water is extracted from the thick descending limb of Henle's loop by osmosis. This is because that region of the medulla is hypotonic. Mannitol, which is an osmotic diuretic, also works at this point, and we'll mention it further down when we cover osmotic diuretics. At the thick ascending limb of Henle's loop, on the other hand, it is relatively impermeable to water, as I mentioned before, but permeable to some solutes. Sodium and chloride are actively reabsorbed to produce dilute tubular fluid. As a result, the segment is known as the diluting segment. The medullary portion accounts for the production of the concentrated urine due to its hypertonic nature. The sodium chloride cotransporter, or the NK, sodium potassium chloride cotransporter, the NKCC2, located on the luminal membrane of the thick ascending limb is responsible for the active reuptake of sodium chloride and is sensitive to loop diuretics. Loop diuretics' mechanism of action is to inhibit apical sodium potassium chloride transporter at the thick ascending limb of Henle's loop. The loop diuretic enters the proximal tubule via organic acid transporter, and they compete with the chloride binding site. As a result, chloride ions build up in the lumen, creating a negative electrical potential, compared to when there is no loop diuretic available around. The accumulation of potassium ions via the ROMK ATP dependent potassium channel active transport plays a role in creating a lumen positive potential. So in the presence of the loop diuretic, the positive lumen potential is not built up, so there's a lumen negative potential. As a result, calcium and magnesium remain in the urine and they are excreted. In addition, there's an increase in potassium and hydrogen excretion in the lumen at these areas in the ascending limb of Henle's loop, as well as in the cortical collecting duct. So loop diuretics selectively inhibit the cotransporter, and they are the most potent diuretics that reduce extracellular fluid, cardiac output, and blood pressure. The prototype loop diuretics include furosemide and ethacrynic acid. All loop diuretics contain sulfur, making them susceptible or able to cause sulfur allergies. The half-life of loop diuretics is dependent on renal function because these diuretics must cross the proximal convoluted tubule to act at the luminal side, so that there's a direct relationship to their half-life and renal function. Metabolites have been identified for some of them, but only for furosemide is there a known active metabolite which has a longer half-life than the active compound in furosemide. Because of the variable bioavailability of furosemide and other agents in this class of drugs, the dosing is a challenge, but there is an estimate dose available for these agents. Due to the blocking of potassium recycling resulting in the loss of lumen positive potential, magnesium and calcium are driven out of the cell, and this can cause hypomagnesemia and hypocalcemia. Therefore, it makes it quite useful in the treatment of patients with high calcium levels, and it can be reverse their calcium levels by using loop diuretics. Loop diuretics are weak inducers of cyclooxygenase 2 and prostaglandin GF2. They inhibit the salt transport at the thick ascending limb, and it affects renal action of loop diuretics. So NSAIDs also have an effect on loop diuretics. NSAIDs, non-steroidal anti-inflammatory drugs such as indomethacin, it stops or inhibits cyclooxygenase activity, and this can interfere with the action of loop diuretics by reducing prostaglandin synthesis in kidneys. This interference of cyclooxygenase by activity by the NSAIDs is not significant in patients with normal kidney function, but it would be important in patients who have nephrogenic syndromes or hepatic cirrhosis, renal and liver disorder. Some of the drug interactions of loop diuretics we may want to note is that because they are bound to plasma proteins, it competes with drugs that would be bound as well. So it displaces agents such as warfarin and clofebrate. Antibiotics such as the aminoglycosides used together with loop diuretics may cause ototoxicity. And also there would be an increase in toxicity when used with drugs such as cephalosporin as well as lithium. And loop diuretics are inhibitors of organic acid ion transport, and it decreases the potency of drugs such as probenecid and non-steroidal anti-inflammatory agents as well. Their indications include cardiac, pulmonary, or renal edema, cardiac failure, hypertension, and to treat hypocalcemia in acute cases. Some of the major side effects and contraindications include hypokalemia, metabolic alkalosis, ototoxicity, hypouricemia, and magnesium depletion. Agents such as furosemide, bumetanide, and torsemide may exhibit cross-reactivity in patients with sulfonamide sensitivity, as I mentioned before. And overuse of diuretics in patients with hepatic cirrhosis, renal failure, and heart failure should be monitored in these patients. At the proximal convoluted tubule, almost all electrolytes, glucose, amino acids, and water are reabsorbed via their transport systems. For example, potassium ions are reabsorbed via the paracellular pathway. Water is reabsorbed passively by the transcellular pathway, mediated by aquaporin 1, and through the paracellular pathway, mediated by claudin 2. Water permeability at the proximal convoluted tubule is high with constant osmolality. So the reabsorption of sodium ions or sodium bicarbonate and sodium chloride are the key point at which diuretics would work at the proximal convoluted tubules. And these include the blocking of the reabsorption of sodium bicarbonate by inhibition of its enzyme carbonic anhydrase, as well as the blockade of the action of sodium hydrogen exchanger located on the luminal membrane. Sodium enters the cell in exchange for hydrogen. And in all portions of the nephron, you'll have the sodium potassium ATPase on the basolateral membrane, which would pump the reabsorbed sodium into the interstitium in order to maintain that low intracellular volume or sodium concentration. The hydrogen that is released in the lumen, it is then available to combine with bicarbonate to form carbonic acid, as you see in the diagram, which rapidly is dehydrated to carbon dioxide and water. The carbon by carbonic anhydrase. The carbon dioxide produced through this dehydration is then diffused into the cell by simple diffusion, and it is rehydrated to carbonic acid in the presence of carbonic anhydrase again. The dissociation into hydrogen ion and bicarbonate allows for the movement of hydrogen back into the lumen, facilitated by the sodium hydrogen exchanger, and bicarbonate is transported out of the cell on the basolateral side by the transporter. Bicarbonate reabsorption is dependent on the function of the enzyme carbonic anhydrase. And these are the key points at which diuretics would work, and we'll explore them now. Carbonic anhydrase inhibitors were the star drug before the 1930s until we discovered sulfonamides for their diuretic purposes. However, carbonic anhydrase inhibitors are used today. Their oral administration allows for rapid absorption or good absorption, as well as increased pH due to the accumulation of bicarbonate ions. Diuresis occurs within 30 minutes of administration with a peak concentration after 2 hours, which lasts up to 12 hours in a single dose of carbonic anhydrase inhibitor. These drugs are excreted at the S2 segment of the proximal convoluted tubule. Therefore, dose monitoring or dose reduction in patients with renal insufficiency is important. Because they inhibit bicarbonate ions, the reabsorption of these ions, and it causes diuresis, they have limited clinical applications today. And one of the major applications is that it's used in the eye to reduce ocular pressure by inhibiting the secretion of bicarbonate ions, which is responsible for the production of aqueous humor by the ciliary bodies. It also works at the cerebrospinal fluid, where bicarbonate secretion by the choroid plexus to form cerebrospinal fluid could be blocked to reduce the production of it. And also, it produces urine by the kidneys, increases urine output by the kidneys. The major indications for carbonic anhydrase inhibitors I mentioned before is in the treatment of open-angle glaucoma to reduce the formation of aqueous humor, thus reducing intraocular pressure. Other agents in the carbonic anhydrase inhibitor class include, as I mentioned, acetazolamide before, dorzolamide, and brinzolamide. Brinzolamide, which is a topical agent, and it has fewer systemic or renal effects than the others. It's also used in urinary alkalization in the cases of kidney stones that are uric acid base or cysteine base. In the case of a cysteine stone, a cysteinuria stone, the pH would need to be increased between 7 and 7.5, and CAIs are quite effective in doing this. While in uric acid stones, the pH goes from 6 to 6.5. As pH range or rise to those levels would help to dissolve the stones and help the patient pass the kidney stones easily. Other uses include, in the case of metabolic alkalosis, is generally treated by the correction of abnormalities due to potassium intravascular volume or mineral corticoid levels in the body. When alkalosis is due to excess diuresis in patients with severe heart failure, replacement of intravascular volume may lead to contraindications, right? So in these cases, acetazolamide can be useful in correcting the alkalosis and produce a small additional diuresis for volume correction of volume overload, It's useful for metabolic alkalosis, also which appears following respiratory acidosis, and also in the treatment of acute mountain sickness, where symptoms of acute mountain sickness would include weakness, dizziness, insomnia, headaches, and nausea. Carbonic anhydrase inhibitors, specifically acetazolamide, may be useful to reduce the progression of pulmonary or cerebral edema caused by mountain sickness. Side effects include a severe reduction in concentration of bicarbonate ions to lead to systemic hypochloremic metabolic acidosis. Because calcium-based renal stones are insoluble in alkaline pH, making the pH of urine more alkaline would cause crystallization of calcium phosphates in the kidney, resulting in kidney stones, including increased sodium and including potassium wasting. So increased sodium and bicarbonate loss would cause a lumen negative potential and cause the excretion or wasting of potassium and phosphorus from the body. So there would be a reduced excretion of ammonia as well, resulting in hyperammonemia, hepatic encephalopathy, and in patients with liver disorders such as cirrhosis. Continuing along the proximal convoluted tubule, normally 90% of the glucose filtered by the glomerulus is reabsorbed at this point. And this occurs through the sodium glucose cotransporter 2. By blocking this cotransporter, about 30 to 50% of that glucose is excreted or lost in urine. In addition, the angiotensin 2 is believed to induce the production of SGLT2 via the angiotensin 1 receptor. Thus, blockade of the renin-angiotensin-aldosterone system might result in low availability of SGLT2. Also, inhibiting the SGLT2 inhibitor, the use of SGLT2 inhibitors for the treatment of diabetes mellitus or the management of diabetes mellitus has been approved as a third-line therapy. These two agents, dapagliflozin and canagliflozin, have been approved in the USA. They are rapidly absorbed through the gastrointestinal tract, and they have been shown to reduce HbA1c by about 0.5 to 1%. The diuretic activity of SGLT2 inhibitors are not approved for diuretic purposes, but they have diuretic activity by reducing sodium and glucose, by increasing sodium and glucose excretion or loss in the urine. One important point to note is that they have drug interactions associated with these drugs, and some include, for canagliflozin, it interacts with metformin as well as hydrochlorothiazide, and some oral contraceptives as well, and anticoagulant agents such as warfarin and cyclosporin and probenecid. So these agents, while they are not diuretics, they do have diuretic activity. Moving on to the collective tubule system. This is the final site which connects to the distal convoluted tubule that feeds into the renal pelvis and to the ureter. It has several segments, and for simplicity we'll call it the collecting tubule system. The segments make up the connecting tubule, the collecting tubule, and the collecting duct. So we look at the principal cells and the intercalated cells that make up the collecting tubule system. In this part of the system, 2 to 5% of sodium chloride is reabsorbed. While it is a small amount of sodium chloride, it is physiologically important, and also the action of diuretics is very important at this site. It is also the final site for sodium chloride reabsorption and is responsible for the regulation of body fluid volume and for determining the final sodium content and the urine. It is also the site where mineralocorticoids exert significant influence and is the most important site for potassium secretion by the kidney, and the site where most diuretic induced changes in potassium balance occurs. The mechanism for sodium chloride reabsorption in the collecting tubule system is distinct from the mechanism of sodium chloride reabsorption in other tubule segments. The collecting tubule system consists of the principal cells, and they are the major sites for sodium, potassium, and water transport. Unlike other segments of the nephron, there is no apical cotransporter system for sodium ion and other ions. Because sodium entry into the principal cell predominates potassium secretion, there is a lumen negative electrical potential. As a result, the sodium that enters the principal cell is transported into the blood through the sodium-potassium ATPase pump, as you see in the diagram. This negative electrical potential also drives chloride ions into the blood, back into the blood by the paracellular pathway, and it draws potassium out of the cells through the apical membrane potassium channel. Other upstream diuretics would produce an increase in sodium delivery here, because remember there's an increase in sodium excretion. At this site, this would enhance potassium secretion into the lumen. So if sodium is delivered to the collecting tubule system with an anion that cannot be reabsorbed, such as bicarbonate, the lumen negative potential would be increased and more potassium would be moved out into the lumen. And this is the mechanism, combined with aldosterone secretion, that would account for the basis of diuretic-induced potassium wasting. So the reabsorption of sodium via the epithelial cells, sodium channel, and its coupled secretion of potassium regulation by aldosterone, where aldosterone increases the apical channel and the basolateral sodium-potassium ATPase. This would lead to an increase in the transepithelial electrical potential and a dramatic increase in both sodium reabsorption and potassium secretion, as I said before. But what is important is that ADH, antidiuretic hormone, arginine vasopressin, whichever one you want to call it, also controls the permeability to water at this point in the principal cell. And it does so by the insertion of aquaporin 2 and urea transporter. So ADH receptors, V1 and V2, V2 of most importance because it's in the kidney, while V1 is in the vasculature and the CNS. They are important to remember because their activation would help to insert more aquaporin 2s and urea transporters into the principal cells for increasing water permeability. And then we have the intercalated cells. They are the primary site for hydrogen and bicarbonate secretion. The alpha and beta intercalated cells are similar, except their location of the hydrogen ATPase and chloride bicarbonate exchanger are on reverse sides of the cells. So in the absence of ADH, in the collecting tubules and the collecting duct, the membrane becomes impermeable to water. So what are the diuretics that we're going to look at? So the first on our list include the potassium sparing diuretics, and these include the aldosterone antagonists. They all antagonize the release of aldosterone in the collecting tubules. This inhibition may occur by direct pharmacological antagonism, such as with the steroid aldosterone antagonists, spironolactone and eplerenone, or by inhibition of sodium ion influx through ion channel and luminal membranes. These include the triamterene and the amyloride. Some of the pharmacokinetics to consider in potassium-sparing agents is that they are orally administered with good bioavailability. Their long half-lives allow for day-full therapeutic effect. They are metabolized through the liver rapidly, and their metabolites are bound to protein plasmas. Toxicity associated with the use of these drugs includes hyperkalemia. And in hyperkalemia, concomitant use with other agents that would stop the renin-angiotensin aldosterone system. And these agents include agents such as beta blockers, ACE inhibitors, and angiotensin receptor blockers. These would increase the likelihood of hyperkalemia and should be monitored in patients before administering potassium-sparing agents. Also, hyperchloremic metabolic acidosis due to the inhibition of hydrogen secretion may occur. and acute renal failure may ensue, as well as kidney stones. So these patients should be monitored for. Right. High doses should only be used for a short period of time as a result. In addition, cytochrome 3A4 inhibitors can increase blood levels of eplerenone, but not spironolactone. And these inhibitors include drugs like erythromycin, diltiazem. Grapefruit juice inhibits cytochrome 3A4. So one of the warnings to place on potassium sparing agents, diuretics, patients who would be admitted to reduce grapefruit juice use. And these agents can increase the levels of eplerenone in patients. Other endocrine effects that may be negative would include gynecomastia in men, amenorrhea in women, and hirsutism, and breastfeeding or breast swelling, and tenderness. There is no report of such endocrine effects with eplerenone compared to the spironolactone, which is its analog. The mechanism of actions are of two types. So mechanism A, as we would call it, would be the competitive inhibition of aldosterone. Spironolactone and eplerenone undergoes this mechanism of action. It also prevents the increased expression of the epithelial sodium channel for the reuptake of sodium from the tubule, luminal tubule, and the phosphorylation of the ROMK channels with respect to potassium secretion. Eplerenone has fewer side effects compared to spironolactone, as I mentioned before. In our second mechanism, it involves the decrease of sodium transport to the collecting duct by the inhibition of sodium ion influx through ion channels in the luminal membrane. Inhibition of reabsorption of these ions via the epithelial sodium channel with coupled inhibition of secretion of potassium on the luminal membrane by trimethylene or amiloride leads to a decrease in potassium loss and an increase in sodium ion in the urine. These are organic acid bases, and they secrete that are secreted into the proximal convoluted tubule to have their effect. Some of the pharmacokinetics of these two agents is that they are quite effective when they're orally administered. Their half-lives are very different. Amiloride has a longer half-life of about 24 hours, while trimethylene is about half that time. Amiloride is not metabolized and is not bound to plasma proteins, while trimethylene is metabolized by the liver into active metabolites. Their toxicities include hyperkalemia and metabolic acidosis. In the gastrointestinal tract, nausea and vomiting and diarrhea may occur. For trimethylene, leg cramps are possible. Increased blood urea nitrogen and uric acid may be observed. These agents are used in cases of aldosteronism, adrenal adenoma, bilateral and adrenal hyperplasia types. It's also used in the treatment of hypokalemia together with other diuretics. In our diagram here, this defines what primary hyperaldosteronism is, so it gives us an idea of how we can use these diuretics to treat this case. The AGH antagonists, or the antidiuretic hormone antagonists. You remember, these control water permeability in the principal cells by insertion of the aquaporin and the UT transporters in the apical side. So the ADH receptors in the vasculator and the central nervous system are V1 type, they interfere with the CNS and the vasculature. So, and those on the that are V2 type, they are located in the kidneys. They'll have renal effects. So patients with congestive heart failure who are on diuretics, they frequently develop hyponatremia secondary to excessive ADH secretion. So in the past, they used lithium and demiclocycline, which is a tetracycline antimicrobial. And they were used before to counteract the ADH secretion, right? The mechanism wasn't too clear, and the side effects of these agents were very numerous. It was numerous. So now there are new agents called the Vaptans that replace the use. And the examples that I have here are the conivaptan, which antagonizes both V1 and V2. So it has side effects associated with vasculature and CNS, in addition to having its antagonistic effect on the kidneys. Tolvaptan is selective for V2, therefore it wouldn't have as many side effects related otherwise. So these agents, they have been approved by the FDA, both conivaptan and tolvaptan. They're currently the only vasopressin receptor antagonists are commercially available and have been approved by the FDA for the treatment of euvolemic hyponatremia in hospitalized patients. These agents, the ADH antagonists, are also used in congestive heart failure for the same reason, with side effects due to excessive ADH secretion, and also in the syndrome of inappropriate ADH secretion. Some of the toxicities associated with these agents include nephrogenic diabetes insipidus setting in. With conivaptan and tolvaptan, they have severe hypernatremia associated with it, polyuria and thirst. Demiclocycline and lithium had lots of side effects associated with it, including renal failure. And tolvaptan should be monitored. You should monitor liver function because it is associated with elevated liver function tests. So now we move on to the osmotic diuretics. And they are substances which freely filter into the glomerulus and limit the reabsorption of water in the tubular lumen. These diuretics, they increase the osmolality in the renal tubule, and they increase the excretion of sodium, potassium, calcium, and many other ions, especially important bicarbonate and magnesium. Absorption and elimination of these agents, the prototype being mannitol, is short and they're eliminated quickly. So urea and mannitol are given IV, and glycerol and isosorbide are taken orally but are less efficient. So how do they work? They increase the osmotic pressure, specifically in the proximal convoluted tubule and in the descending limb of Henle's loop. They prevent passive reabsorption of water, and they oppose the action of ADH in the collecting tubule. So when natriuresis is reduced, there's an increased urine flow, reduced contact time between fluid and tubular epithelium. Therefore, sodium and water reabsorption is reduced, and the solutes are forced out through that osmotic force to release water and those electrolytes. These are agents used in renal failure induced by increased solute load, rhabdomyolysis, and chemotherapy, increased intracranial pressure, as well as in increased aqueous humor due to glaucoma. There are side effects associated with them, and these include extracellular fluid volume expansion as well as water excretion. The renal autocoids. Adenosine is an unphosphorylated ribonucleoside with action on the kidney. Adenosine concentration increases in hypoxia, and hypoxia results in compensatory vasodilation. If cardiac output is sufficient, there'd be an increase in blood flow at this point. But in the kidney, an increase in blood flow would cause an increase in glomerular filtration rate, therefore an increase in electrolytes and solute to the tubule. This increase would cause an increase in work using ATP. So what happens in a hypoxic kidney is that there's a decrease in blood flow, a reduction in glomerular filtration rate, and this is because the medulla is more hypoxic than the cortex. So in high levels of adenosine, that is what happens: lower blood flow, lower glomerular filtration rate. The receptor types of the adenosine receptor include A1, 2AB, and 3. They are all found in the kidney, but only A1 is of importance because it is found on the proximal convoluted tubule and the preglomerular afferent arteriole. It is also found on other segments of the nephron. Adenosine is known to affect the transport in the proximal convoluted tubule, the thick ascending limb of Henle's loop, and the collecting duct. These receptors, when they are antagonized, they have been found to block the enhancement of the sodium hydrogen exchanger activity. And what happens is this causes the diuretic activity. And they also do not enhance potassium secretion, so they prevent potassium wasting. Some of the examples of these antagonists include the selective rolophylline. The others include caffeine and theophylline, which have weak activity, and theobromide. So this brings us to the end of our session on diuretic drugs. So we've covered all 7 classes: the carbonic anhydrase inhibitors, the osmotic diuretics, the loop diuretics, the thiazides, the aldosterone antagonists, the ADH antagonists, and the adenosines antagonists. So we've related them to clinical uses, which include heart failure, kidney and liver failure, hypertension, nephrolithiasis, hypercalcemia, just to name a few. So if you have any questions relating to diuretic drugs, please feel free to ask here in the chat box or to email so that we can address these questions. I hope you enjoyed diuretic drugs,